What are aortic emergencies? So aortic emergencies, they are a group of acute life-threatening conditions involving the aorta that require immediate intervention to prevent the fatal outcomes. So the entities that fall under the aortic emergencies are ruptured aneurysm, pseudoaneurysm, the aortic dissection, intramural hematoma, penetrating atherosclerotic ulcers, and aortic injuries. So these three entities, dissection, hematoma, and penetrating ulcer, they also fall under acute aortic syndromes. So why CT is the preferred modality? Because it helps us in fast acquisition with high spatial resolution. It provides the proper surgical roadmap for planning, and it easily evaluates the entire aorta as well as the branch vessels. So CT doesn't just diagnose the aortic diseases, but it directs the management. So the protocol that is followed is the coverage should be from the region of thoracic inlet to the femoral arteries, and the phases that used are the non-contrast phase. It is mandatory because it is the phase which detects the presence of the intramural hematoma or the high attenuation crescent in the cases of the impending rupture. And arterial phase is the main diagnostic phase, and delayed phase also has its own utility. So the protocol, to 70 to 100 ml of non-ionic contrast is injected, and it should always be injected from the right arm, because if we inject from the left arm, then the contrast will cross in front of the aorta and it can give streak artifacts. And 4 to 5 ml per second of injection rate should be maintained, and 30 to 40 ml of saline flush is given, and the bolus tracking is placed in ascending aorta with trigger at around 120 HU. So the important modifications that can be done in routine aortogram, the ECG gating study. So it is essential when we want to evaluate for the aortic root or ascending aorta, because it reduces the motion artifact and helps prevents the false flap diagnosis. Also, delayed phase is used when there is suspected rupture with delayed leak, when there is suspected malperfusion to the visceral organs, and also to differentiate thrombosed false lumen with the slow filling of the false lumen. And low kV of up to 80 kV, it sometimes provides better vascular opacification in the cases of thin patients. Also, it helps in lowering the radiation dose by around 20 to 40%. Also, thin slice acquisition should be done. It is required for the intimal tear detection and for the proper 3D reconstructions. And if the service is available, then the dual energy CT, it helps in detecting the subtle leaks by means of iodine mapping. Also, the high monochromatic beams, they helps in reducing artifact in presence of stents and coils, and low monochromatic imaging, it helps in contrast enhancement. So the most cases of the dissections are protocol failure but not the interpretation failure. So we should know a little bit about the aortic anatomy. So this is the region of the aortic root. So this is the aortic root. This is the sino-aortic annulus, sinus of Valsalva, sinotubular junction, the ascending aorta, arch of aorta, aortic isthmus, descending thoracic aorta, and the abdominal aorta. These are the places where the measurements should be done for the cases of the CT aortogram. So starting with the aneurysm. So aneurysm, when do we call the vessel aneurysmal? So when the diameter of the distal segment it becomes 1.5 times compared to the proximal segment, and for the descending aorta, if the diameter exceeds 3 cm, and for the ascending aorta, if the diameter exceeds 4.5 cm, some authors consider it to be 5 cm, then it is considered to be aneurysmal. And the cases between 4 to 5 cm, 4 to 4.5 cm, it is considered to be dilated or ectatic aorta. And in cases of the ascending aorta, when the diameter goes more than 5 cm, then there is high risk of rupture. In cases of the heritable cases, even if it goes more than 4.5 cm, then there is increased risk of rupture. So aneurysm can be either fusiform or saccular. Mycotic aneurysms are usually saccular. True aneurysm contains all three wall layers, while pseudoaneurysm, it has no intima in the wall and it is bound by adventitia or surrounding soft tissue and be connected to parent vessel by a neck. An aneurysm can have thrombus, calcification in the wall as well as within the thrombus. So where you can see the case of the large saccular aneurysm in the distal aortic arch with eccentric hypotenuse filling the defect suggestive of thrombus. Here also we can see small saccular aneurysm arising from the distal aortic arch. So what are the signs when the aneurysm ruptures? So the primary signs are extravasation of the contrast and the periodic hematoma. As we can see in this case, this is the case of the abdominal aortic aneurysm, and we can see a large retroperitoneal hematoma adjacent to it. So it is the primary sign. And also in this case we can see there is a aneurysm in the aortic arch, the saccular aneurysm with periaortic hematoma. And the interesting thing is the periaortic hematoma also tracked into the pericardium, causing the hemopericardium. So what are the signs that the aneurysm is impending to rupture? So the signs of the impending rupture are if it increases by more than 10 mm in a year in serial imaging, if the diameter of the abdominal aorta it exceeds by 7 cm, the high attenuation crescent sign, draped aorta sign, and focal wall intimal calcification discontinuity or tangential calcium sign. So what are these? So we can see in this case this is the aneurysm of the abdominal aorta, and we can see there is break in the intimal calcification. Also there is periaortic soft tissue which is draping into the vertebral body, giving the draped aorta sign. So it is the sign of the impending rupture. Also in this case we can see there is a large descending thoracic aortic aneurysm with a crescent of high density in periphery. So this is the high attenuation crescent sign. It also shows the importance of the non-contrast images in detecting the impending rupture. So one term we should be aware of is the annular aortic ectasia. So it is the degenerative disease with cystic medial necrosis causing the dilatation of the aortic root and proximal aorta. So it is usually seen in the congenital conditions like the Marfan's and Ehlers-Danlos, and it is the predisposing factor for the dissection, rupture, and regurgitation. So the typical imaging feature is the tulip bulb sign, as seen in this case, where it resembles the bulb of a tulip. And the typical striking feature is failure to identify the proper sinotubular junction, like in this case. So in the case where you cannot see the sinotubular junction properly, then you should suspect annulo-aortic ectasia. So there is another entity called the sinus of Valsalva aneurysm. So it is sinus of Valsalva is considered to be aneurysmal when it exceeds more than 4 cm in male, more than 3.6 cm in female. And why we should know about it? Because it has the complications like it can rupture, and when the right cusp rupture, it can rupture into the right ventricle. Non-coronary cusp can rupture into right atrium, and left coronary cusps it can rupture into the left atrial appendage. So this is the case of right sinus of Valsalva aneurysm. So now talking about the dissection. So dissection is the separation of the aortic media by stream of blood by an intimal tear, creating the false lumen. So the predisposing factors are similar like hypertension and the congenital conditions, and the classic findings are presence of the intimal flap and the creation of the true and false lumen. So the classification is commonly done by the Stanford classification. If it involves the ascending aorta, then it is the type A, which needs surgical management. If it is distal to left subclavian artery, then the medical management can be done. If it is uncomplicated, it is the type B. So we have to differentiate between the true and false lumen for the reporting. So the true lumen are usually smaller, so early enhancement, so direct continuity with normal aorta and has intimal calcification in its wall. False lumen is usually larger, shows the big sign, cobweb sign, and delayed enhancement. So what is it? We can see there are two lumens. So the smaller one is usually the true lumen and the larger one is the false lumen, where we can also see the flap is making acute angle with the wall, giving the big sign. So this larger one is the false lumen. Also cobweb sign means there are the hypodense soft tissue like structures which are usually in the side of the true lumen, which usually represents the sheared soft tissue of the media done by the dissection. So this image shows the importance of the ECG gated CT, where we can see here we cannot clearly make out the nature of the flap, but here we can see there is a clear intimal flap. Also the fenestration can be seen. So this is the utility of the ECG gated CT in cases of the proximal dissections. So what happens to the false lumen? So false lumen can get thrombosed, it can decrease over time, increase over time, and become aneurysmal, and it can also rupture. So what are the points to be included in the report? So the points to be included are the type of the dissection, the intra-tear location, the extent of the dissection, involvement of the great vessels, also the involvement of the branches of the abdominal aorta, the size of the false lumen, whether it is causing the compression of the true lumen, the presence of the fenestrations, the complications, and the landing zones, and the information about the landing zones if the vascular intervention is planned. So now, intramural hematoma. So intramural hematoma is more common in the descending aorta compared to ascending aorta. So there are two postulated hypotheses. One is if there is the rupture of the vasovasorum, in these cases the hematoma occurs without the intimal tear, and other postulated hypothesis is it is the form of the limited dissection where there is micro tear but the thrombus in the false lumen, but there is the thrombosis of the false lumen. So intramural hematoma, it also appears as the crescentic high attenuation in non-contrast images. It has no flap is seen. The wall thickness is usually more than 5 mm, and when it is more than 10 mm, there is high risk of progression. And this sequelae, it can go into dissection, rupture, it can regress, resolute, or it can also go into aneurysm development. And thrombosed false lumen in the dissection can mimic the intramural hematoma, but the clue is the false lumen usually has the spiral course, while the intramural hematoma is usually localized. In this case, we can see the intramural hematoma in the aortic arch appearing as the high attenuation in the wall with thickening, and we see in the non-contrast images as the filling defect, and it can be easily confused with the thrombus when the non-contrast image is not seen. So also when the intramural hematoma involves the aortic root, then it has the tendency to track along the pulmonary artery, because the aortic root and the main pulmonary artery, they share the same adventitia. Like seen in this case, the hematoma is tracking towards the pulmonary artery from the aortic root. Now, penetrating atherosclerotic ulcer. So it is the ulcerated plaque that has penetrated into the internal elastic lamina usually with surrounding intramural hematoma. It can also lead to pseudoaneurysm and dissection. It is often seen in elderly with severe atherosclerosis, and the most common site is middle and distal third of the thoracic aorta. Imaging findings is the focal ulcer in the plaque, which appears as the outpouching, which is extending beyond the aortic contour, and it is usually associated with the hematoma, which may be short segment and sometimes extensive also. And it is different from the plaque ulceration in that the plaque ulceration does not penetrate the intima. So here we can see the outpouching has extended beyond the normal aortic contour, and there is the surrounding hematoma in both of these cases. So these were the cases of the penetrating ulcers. Also, there is one entity called the intimal tear without mural hematoma, which is also called flapless acute aorta, limited intimal tear or incomplete dissection, where there is intimal tear but there is no hematoma or the propagation of the false lumen, and it can be very difficult to diagnose unless there is the availability of ECG gated CT. So there is one new classification scheme which classifies the dissection or the acute aortic syndrome, where the aorta is divided into various segments, and it is classified on the basis of intra-tear location. So on the basis of intra-tear location, if it is in the zone 0, then it is A-type aortic emergency, and if it is not, intra-tear is not in 0, then it is B-type emergency. If it cannot be made out, then it is indeterminate type, but the extent should be added in the suffix. Like in this case, if it begins in the segment B, then the proximal and distal extent should be made. So it is not mandatory, but sometimes the surgeons find it comfortable when we classify in this way. So now shortly about the aortic injury. The imaging findings are similar, but how it is graded? So only the presence of the intimal flap is the grade 1. The presence of the intramural hematoma is grade 2, pseudoaneurysm grade 3, and the rupture is grade 4. But the interesting thing is the rupture, that is the highest grade injury, is the one that is most commonly encountered, which is more common than the other entities, and the most common site is the aortic isthmus. So this was the case we encountered in the 26-year-old male in motor vehicle accident. Here we can see the intimal tear showing the discontinuity, and interesting thing is no other injuries were associated in this case, and no other visceral injuries or the spine injuries were seen, and it was the isolated case which was managed conservatively. So CT aortogram is a protocol-driven emergency study. Accurate technique, recognition of subtle findings, and structure reporting directly influence the survival. Thank you.